Hello and welcome to SRG's Medicine. Today, in this video of Respiratory Medicine Series, we shall be continuing our talks on dyspnea. So, the contents of this video are physical examination, general tips, laboratory studies, pitfalls, and ultimately, summary. So, let's start with physical examination. In physical examination, the first thing that we examine in a patient with dyspnea is vitals. So, in vitals, we have a mnemonic that is A, B, C, T, which stands out for airway, breathing, circulation, and temperature. Though in other emergency cases, we consider vital as A, B, C, D, E, but here, specifically in physical examination, we are considering only airway, breathing, circulation, and temperature. So let's start with airway. So if there's presence of signs of wheezing or stridor or narrowed airway, then we have to consider pulmonary condition as a cause of dyspnea. In breathing rates or patterns, the first one is tachypnea. So the normal adult breathing rate is 12 to 20 breaths per minute, whereas in the pediatric group, it's from 40 to 55 or 60 breaths per minute. So now in the cases of adult, if it's greater than 20 or 25 breaths per minute, then it is known as tachypnea. And in such condition, the causes for dyspnea could be cardiac causes, vascular causes, miscellaneous causes, or obstructive pulmonary causes. Whereas the cases of bradypnea, that is decreased breathing rate, that is less than 10 breaths per minute. So in such condition, the causes could be restrictive lung diseases or chest wall and pleural disorders, specifically those disorders which are causing decrease in the expansivity or contractility of the thorax and pleural cavity. So we have other abnormal breathing patterns. So in other abnormal breathing patterns, there are several different kinds of breathing patterns, such as Kussmaul's breathing pattern or Kussmaul's respiration, Biot's respiration, Cheyne-Stokes respiration, etc. So these will be covered in the later videos, in specifically on the abnormal breathing pattern. But for now, we also have to look onto any abnormal breathing pattern, and the causes would be specifically according to the abnormal breathing pattern. The next thing that we see over here is circulation. So in circulation, we have two things. First one is blood pressure. The next thing is pulse rate. So keeping this in a table. So if there is hypertension along with tachycardia, then the cause could be shock or some pericardial causes such as restrictive pericarditis, cardiac tamponade, or pericardial calcifications, etc. Whereas if there is hypertension along with bradycardia, then the causes might be cardiomyopathies or decompensated, or also known as final stage of congestive cardiac failure. So if there is hypertension along with tachycardia, so hypertension along with tachycardia can be presented in infection or in the compensated stage of congestive heart failure. Whereas if there is presence of hypertension along with bradycardia, then most commonly it occurs due to autonomic dysfunction. For example, in cases of pheochromocytoma, if there is any other causes, simultaneous causes, which leads to excessive activation of vagal system or vagal compression or irritation. In such condition, there is bradycardia due to vagal activation. However, due to adrenergic actions, there is presence of hypertension. So such kind of things can occur in autonomic dysfunction. So various kinds of autonomic dysfunction. And the other cause over here could be congestive cardiac failure, which is progressing from compensated to decompensated. So that can be the causes over here. And the final thing that we'll be looking on is for temperature. So in temperature, we generally have increased temperature. So the causes of increased temperature could be infection, any kind of inflammatory conditions, specifically systemic inflammatory conditions, and acute exacerbation of previous pulmonary condition, for example, asthma or COPD. So the next thing that we'll be looking on in vital examination is inspection. So in inspection, we check for pallor. So if there's pallor, then we have to consider anemia as a cause. If there's icterus, then the cause could be liver disease or hemolytic anemia. If there is cyanosis, then the cause could be vascular or cardiac dysfunction, specifically those which cause decrease in the cardiac output as well as in the peripheral vasoconstrictions. And also we can see clubbing. If there's presence of clubbing, then we have to consider hepatic, pulmonary, or renal causes. Though you might think that renal causes are not much important as a cause for dyspnea, but renal causes lead to uremia, and uremia leads to a central sensation or stimulation, leading to a sensation of dyspnea. So that can be a cause. The next thing is edema. The causes of edema could be cardiac or thromboembolic disorder along with dyspnea. And then if there is lymphadenopathy, then we can consider the presence of neoplasms. And if there are any signs of dehydration, for example, dry mucous membrane, sunken eyes or sunken fontanelles or any other signs of this dehydration, then in such condition, we have to consider hypovolemia or shock as a cause of dyspnea. So these all lie under general examination, and this can be summarized by a mnemonic: pick cold, that is pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy, and dehydration. So the next thing that we'll be looking on is the cardiovascular and respiratory signs and symptoms in inspection. For example, the signs of respiratory distress such as increased use of accessory muscles or nasal flaring, tripod position, etc. And both chest and abdominal movement and hyperinflation of lungs or distended neck pains or any other things that is prominent or we can see on the inspection of cardiovascular and respiratory system. So I'll be talking about why we need to see both chest and abdomen, not just solely chest, but rather both chest and abdomen movements in case of a patient with dyspnea. So this I'll be talking on in the later part of this video. So for now, let's move on to palpation. So in palpation, we have to palpate if there's presence of any lymphadenopathy. We have to palpate for tactile vocal phrenitis. There's diminishing vocal phrenitis or excessive vocal phrenitis. And then we have to see for abnormal pulsation, if any present in the surface area of the thorax. And also we have to look for jugular venous pulsation and measure it. And the next thing we do is percussion. In percussion, we specifically do percussion for a pulmonary condition, because in the cases of cardiac condition, via percussion, we get not much information except for the cardiac border, and that is not useful for us in the case of dyspnea. So we have to do it specifically focusing our attention on the lungs and its border or any kind of disorders that we can find out via percussion. And ultimately, we move on to auscultation. In auscultation, we have to look for both pulmonary as well as cardiac sounds, such as wheezes, rhonchi, breath sounds, or heart murmurs, and heart sounds. Heart sounds also specifically S3 and S4, because these are not normally present in a normal individual, and these points towards the causes of valvular disorders or arrhythmias. And the next thing, which is most important here, which I have also kept in bold, is pulsus paradoxus. So what is pulsus paradoxus? Normally, in a normal individual, what happens is whenever we inspire, the blood pressure, specifically systolic blood pressure, decreases by around 3 to 5 millimeter of mercury on inspiration and goes back to normal on expiration. Whereas in this condition, so that is in pulsus paradoxus, systolic BP decreases by greater than 10 millimeter of mercury on inspiration. So the causes for pulsus paradoxus can be COPD, acute asthma, or pericardial diseases. Here, most importantly, we have to note pericardial diseases, because though in COPD and acute asthma, pulsus paradoxus might be present, but pulsus paradoxus is a must in case of pericardial diseases. So this is most important part for the physical examination that I've talked about in this slide. And now moving on to our next part, that is general tips. So for general tips, now firstly, I'll be covering about why we need to look both the chest and abdomen, not just solely chest, for patients with dyspnea. So the basic physiology there is that during inhalation, as we can see here in this picture, during inhalation, there is inspiration of air and diaphragm also contracts, so moves downwards, such that there is increased pressure on the abdominal contents and abdomen bulges outwards, so belly is outwards. Whereas during expiration, the thoracic cavity also decreases in size. Along with that, air goes out and diaphragm relaxes to its normal position. Thereby, the pressure on the abdomen is relieved. So the abdomen comes back to its normal position. So belly goes inwards. So that is during exhalation. So during inspiration, abdomen comes outward, whereas during expiration, abdomen goes inside. So that is a normal physiology. But there might be some condition. For example, during pulmonary edema, if there is rounding of abdomen during expiration. So normally during expiration, the abdomen must have been flat or must have gone inside. But if there is presence of rounding of abdomen during expiration, then that is a telltale sign of pulmonary edema. As you can see here, during expiration, the chest wall is decreasing in size, but this, as you can see here, the abdomen is rounded. So that is a sign of pulmonary edema. The next step is if there is inward motion of abdomen during inspiration, then that is a sign of diaphragmatic weakness. Because during inspiration, normally the abdomen must bulge out. However, if there is inward motion of abdomen, then that is a sign of diaphragmatic weakness. So as you can see here, there is increase in the size of the thoracic cavity, that is on inspiration, but the abdomen is flat. It hasn't bulged out. So this is a sign of diaphragmatic weakness. Now talking about our next thing, that is the patients should be asked to work on the observation with oximetry to reproduce the symptom. So why is that with oximetry? Because if we do observation with pulse oximetry, then we can find the reduction in oxygen saturation and mention it in the report. And the next thing is that if there occurs severe reduction of the oxygen concentration in blood when there is patient is performing walking or any other kind of exercise, then we have to immediately abort the observation and then stabilize the patient. So that will also help us prevent from the emergency of decreased saturation of oxygen, because normally we cannot just look at the patient and say that the saturation of oxygen is decreasing or increasing. So that is helped by the use of pulse oximetry along with exercise on observation. So the next thing is that the patient should be examined both during rest as well as the end of a exercise. Any kind of exercise that will be relevant to the patient or the scenario, whether that be walking or treadmill exercise or cycling exercise or any other kinds of exercise according to the situation. So the patient should be examined during rest and at the end of exercise for seeing if there's presence of any new findings, for example, wheezing, cyanosis, or any other kinds of signs, which were not present at the beginning, that is during rest, but are present at the end of exercise. So for finding these findings also, we need to perform at rest and during at the end of exercise. Whereas also it is done to note the changes in oxygen saturation and for interpreting the severity in day-to-day life, because the secondary physiological responses that we see in patient helps us to clearly reflect on the patient's severity of dyspnea during exercise. So normally if the patient is at rest and it looks normal, then we might not be able to assess the severity of dyspnea in patient. But if we perform the exercise and then at the end of exercise, look at the patient for presence of any other kind of secondary signs or responses by the body, then we can interpret the severity in the patient. And the next thing is that pulmonary vasculature, if prominent in chest X-ray in the upper lobes, will suggest us pulmonary venous hypertension, whereas that centrally will suggest us pulmonary arterial hypertension. So this is an important one here, because if upper lobes have prominent pulmonary vasculature, so which suggests pulmonary venous hypertension. So in such condition, on venous hypertension, we have to think the cause for this venous hypertension might be located somewhere in the left heart. So either that might be mitral stenosis, aortic stenosis, regurgitation, or any other process which causes debilitation of the left side of the heart. Whereas if that prominent pulmonary vasculature is on the central location on the chest X-ray towards the lung field, on the central area of lung field, then we have to consider about the pulmonary arterial hypertension. And this is important because pulmonary arterial hypertension usually occurs due to presence of right-sided heart failure, or as we say, cor pulmonale. And over here, we see systemic signs of edema and also raised jugular venous pressure and any other kinds of signs and symptoms. And the thing to be noted here is that the causes as well as the management plan for the left-sided and right-sided heart diseases are different. So that's why we need to note this thing in case of chest X-ray. So the last thing that I'll be talking here is that a coarse flap or tremor of the outstretched hand will indicate us presence of carbon dioxide poisoning. But the thing to be noted here is that this is just a coarse flap or tremor, but not a flapping tremor as we see in hepatic encephalopathy. So that needs to be differentiated from carbon dioxide poisoning. So let's move on to our laboratory studies. So we have classified it into three phases, phase 1, 2, and 3, such that phase 1 includes chest x-ray, spirometry, electrocardiogram, complete blood count, serum electrolyte, and arterial blood gas analysis. So now these all are done to rule out the cause for dyspnea. So, for example, by chest X-ray, we can see pulmonary or vascular diseases. By spirometry, specifically pulmonary ones. By ECG, we can look for the cardiac ones. By CBC, we can look for any infectious causes or malignancy or inflammatory causes. By serum electrolyte or ABG, we can look for miscellaneous causes that we had listed over there, such as neoplasms or metabolic acidosis or any other conditions that we might say. And once these phase 1 tests are completed, if we have a specific diagnosis, then we do not need to perform the other phases of laboratory studies. However, if our diagnosis is not clear or not definite, then we have to go on to phase 2, so which includes chest CT. And if we suspect for thromboembolic diseases, then we have to do angiography. Otherwise, there are also like tests like lung volume, diffusing capacity of lungs for carbon monoxide, echocardiography, cardiac stress testing, and also tests of neuromuscular functions. So if all these tests also give us non-definite results, so that is there's no definite results, then we have to move on to phase 3, which includes cardiopulmonary exercise testing, and this is usually performed on a specialized center. So specifically cardiologist or pulmonologist perform these kind of cardiopulmonary exercise testing, not on the primary healthcare center. So after that, we have to look for the pitfalls. So few specific pitfalls which are not just fatal on a given time. However, they might produce some complications that ultimately lead to fatal diseases or fatal condition in a patient. These include interstitial lung diseases like idiopathic pulmonary fibrosis, sarcoidosis, and extrinsic allergic alveolitis, or chemical pneumonitis. Specifically, here we are talking about the unknown gastroesophageal reflux, which is aspirated, leading to chemical pneumonitis. And the next thing is metabolic acidosis, renal failure or uremia, as we had already mentioned earlier as well, and also multiple small pulmonary emboli and radiotherapy. Here, the point that I would like to note here is that in cases of chemical pneumonitis, antibiotic therapy needs to be given for the anaerobic infections as well as for aerobic infection, unlike the other pneumonias in which we give specifically for aerobic gram-positive and gram-negative organisms. Here we give for both aerobic as well as anaerobic. So the management is different. So we need to know whether that's chemical pneumonitis or not. And for the renal failure, that might be like your first sign might be just clinical symptoms that patient might present with would be dyspnea rather than any other renal sign. So early diagnosis will be easier if we also suspect if there's presence of renal failure or not, and then we can confirm it by the presence of blood urea nitrogen. And radiotherapy is usually not missed. However, if the patient is unconscious or comatose or is not responding or is in a psychiatric conditions, then his or her statement might not be quite reliable. So in such condition, uh, we might not suspect that the radiotherapy might be a cause for dyspnea, but sometimes the patient might have come with radiotherapy and that might have caused a lung injury leading to dyspnea, but we might not know it. So these were the pitfalls. Now talking about summary. Vitals, that is airway, breathing, circulation, and temperature. And inspection, pick, cold, and cardiorespiratory inspection, palpation, pulmonary percussion, and auscultation for cardiorespiratory sounds, and ultimately pulsus paradoxes. They are the important part for physical examination. Lab investigation can be done in three phases, starting from chest X-ray, ECG, spirometry, etc., and moving towards ultimately to phase 3, which includes cardiopulmonary exercise testing. There are a few important pitfalls which must be kept in the back of head while diagnosing the cause of dyspnea so as to not miss it, because they are not fatal themselves. However, they cause complications which lead to few dangerous fatalities. So hope you enjoyed it. Thank you. Please stay tuned for my other videos and be sure to comment.